Hi, this is Philip Ador, founder of NCLEX RN 45-Day Challenge. In this video, I'm going to be talking about post-operative nursing. You might have heard the term perioperative nursing. This encompasses the preoperative, intraoperative, and post-operative phase of the patient's surgical experience. This video will focus on the post-operative phase, which begins with the patient's admissions to the post-anesthesia care unit or PACU, and ends once the anesthesia has worn off enough for the patients to be safely transferred to the appropriate nursing unit. The post-anesthesia nurse must understand the patient's risk for complications and be prepared to implement interventions should there be a change in the patient's status. Nursing interventions include monitoring vital signs, airways, pain, neurologic status, managing pain, assessing the surgical site, assessing and maintaining fluid and electrolyte balance, and providing a thorough report of the patient's status to the receiving nurse on the unit, as well as the patient's family. The patient must be able to free off the symptoms of complications in order to transfer from the PACU to the clinical unit or home. However, the potential for developing complications goes beyond the immediate post-operative phase. An ongoing nursing assessment is essential on the post-operative nursing floor as well. In this video, we'll be focusing on the immediate post-operative care in the PACU. The PACU should be located near the operating room. It is usually a large open room divided into individual patients' care spaces. There are usually 1 1/2 to 2 patients' care spaces per operating room. Each patient care space is supplied with a blood pressure monitoring device, cardiac monitor, pulse oximeter, oxygen, airway management equipment, and suction. Emergency equipment and medications are often centrally located. The length of stay in the PACU is determined in a case-to-case basis. There is not a mandate for a minimum stay requirement. The American Society of Peri-Anesthesia Nurse recommends that the critically ill patients do not recover in the same area as ambulatory surgical patients. Registered nurses in the PACU demonstrates in the depth of knowledge of patients' response to anesthetic agents, surgical procedures, pain management, and potential complications. There are 3 phases of post-anesthesia care. One phase is the immediate post-anesthesia period when the patient is emerging from the anesthesia and requires one-on-one care. The PACU nurse assesses the level of consciousness, breath sounds, respiratory efforts, oxygen saturations, blood pressure, cardiac rhythm, and muscle strain. The patient is being prepared for transfer to Phase 2, ICU or an inpatient nursing unit. Phase 2 is continued recovery when the patient's consciousness returns to baseline and the patient has a stable pulmonary, cardiac, and renal functioning. Many patients bypass Phase 1 and go directly from the OR to the Phase 2. This process is known as the fast tracking. The patient then moves to Phase 3, home or an extended care facility. Phase 3 is an ongoing care for the patients needing extended observations and interventions after Phase 1 or 2, such as a 23-hour observations unit or in a hospital unit. Nursing care continues until the patient's care completely recovers from the anesthesia and surgery and is ready for self-care. The PACU nurse will receive the detailed verbal report from the circulating or nurse and or anesthesiologist that is bringing the patient to the recovery. The PACU nurse performs an immediate assessment of the airway, respiratory, and the circulatory status. Immediate post-anesthesia nursing care or Phase 1 focuses on maintaining ventilations, circulations, monitoring oxygen and level of consciousness, preventing shock, and managing pain. The nurse should assess and document respiratory, circulatory, and neurologic functions frequently. Neurologic functions can be assessed by the patient's response to verbal stimuli, pupils, responsiveness to light, and accommodation, ability to move all extremities and strength, and the quality of the hand grip. A level of consciousness assessment is also helpful, such as the AVP U scale or the Glasgow Coma scale. The AVP U scale assesses if the patient is alert, response to voice, response to pain, or unresponsive. The Glasgow Coma Scale is an objective way to record the consciousness state of a patient, examining eye, verbal, and motor response. The lowest possible score is 3, indicating deep coma or death, while the highest score is 15, which is a fully awake person. Assessment of the respiratory status may include pulse oximetry, arterial blood gases, and a chest X-ray. Respiratory complications exist for all patients and include airway obstruction, hypoxemia, hypoventilations, aspirations, and the laryngeal spasm. Airway obstruction is a serious complication after general anesthesia, and commonly results from the movements of the tongue into the posterior pharynx. Changes in the pharyngeal and the laryngeal muscle tone or laryngeal spasm, edema, and secretions of the fluids collecting in the pharynx, bronchial 3, or trachea. Symptoms include gurgling, wheezing, stridor retractions, hypoxemia, and hypercapnia. Treatment includes administering of 100% oxygen, suctioning of the secretions, jaw thrust maneuvers, and to maintain airway and insertion of an oral or nasal airway. If none of these interventions are successful, then endotracheal intubations or cracothyroidectomy or tracheostomy may be necessary. Patients with obstructive sleep apnea have a complete or partial collapse of the pharynx during inspirations and are increased risk of airway obstructions from the effect of anesthesia. They are also at risk for hypoxemia because of the residual effects of anesthesia agents. The nurse should monitor the patient for apnea, dysrhythmias, and continuously monitor oxygen saturations. Hypoxemia is a common complication in the immediate post-operative period when pulse oximetry is less than 90% and PO2 is less than 16 millimeters of mercury per AVG. It may be a result of the hypoventilations related to opioids causing respiratory center depressions on general anesthesia. Insufficient reversal of neuromuscular blocking agents resulting in the residual muscles or paralysis. Increase in tissue resistance from the emphysema or infections. Decreased lung and chest wall compliance from the pneumonia, obesity, or gastric abnormal distensions. Incision site close to the diaphragm, constrictive dressings, or post-operative pain. Aspiration is when gastric contents or blood is inhaled into the trachea, into the bronchial system. It is usually caused by regurgitations. However, the blood may result from the trauma or surgical manipulations. Risk for aspirations is the reasons for the patient's need to NPO prior to surgery. So there is nothing on the stomach. Aspirations of gastric contents can cause pneumonias, chemical irritations, destructions of tracheobronchial mucosa, and secondary infection. The laryngospasm is another respiratory complication in which the laryngeal muscles tissues spasms and causes a complete or partial closures of the vocal cords, resulting in the airway obstruction. If not treated, laryngospasms can result in hypoxemia, cerebral damage, and death. If the patient is extubated too quickly, they are at risk of airway spasms, aspirations, coughing, airway obstructions. If there is a repeated suctioning and irritations by the ET tube or the artificial airway. Laryngospasms can occur after activations. Symptoms of laryngospasms include dyspnea, curling sounds, hypoxemia, and hypercapnia. Treatment includes removing the irritating stimulus, hyperextending the patient's neck, elevating the head of the bed, giving oxygens, suctioning if necessary, and positive pressures, ventilations by bag and mask. The medications may be given to reduce swelling in airway irritations or muscle relaxants may be treated. Reintubating is only done as a last resort. The most common encountered cardiovascular complications are hypotensions, hypertension, and cardiac dysrhythmias that occur as a result of anesthetic agents affecting the central nervous system, myocardium, and peripheral vascular system. The signs of hypotensions include increased heart rate, systolic pressures of 90 millimeters, mercury or less, decreased urinary output, pale extremities, confusions, and restlessness. A common cause of postoperative hypotension is blood loss and inadequate fluid replacement. The PACU nurse should be ready to return the patient to the OR if excessive bleeding or hemorrhage occurs. Hypertension can also occur in postoperative due to the patient's pre-existing hypertension, sympathetic stimulations. Hypertension can also occur postoperatively due to the pain, pre-existing hypertension, sympathetic stimulations, bladder distensions, anxiety or reflex vasoconstrictions due to hypoxia, hypercapnia, or hyperthermia. Untreated hypertensions may lead to cardiac dysrhythmias, left ventricular failure, myocardial ischemia, infarctions, pulmonary edema, and cerebral vascular accident. The hypertension must be adequately treated before the patient is discharged from the PACU. Sinus tachycardia, sinus bradycardia, and supraventricular dysrhythmias. The nurse should assess for the airway patency, adequate ventilations, and administer medications and supplemental oxygen as needed. The PACU nurse is also responsible for monitoring the patient's temperature, as a normal thermoregulation is often disrupted due to the medications, anesthesia, and the stress of surgery. Many patients experience hyperthermia, which can extend recovery, delay wound healing, and increase post-operative morbidity. Shivering increases oxygen demands up to 400%, which results in the increased metabolic rate and myocardial workload. Hypothermia also impairs coagulations, causes decreased cerebral blood flow, and vasoconstrictions. Signs of hypothermia include shivering, tachypnea, and tachycardia. Rewarming is essential in the immediate post-operative care of the patients in PACU. Hyperthermia when the core temperature gets above 102.2 degrees Fahrenheit and may be caused by infections, sepsis, or malignant hyperthermia, which can occur for 24 to 72 hours after the surgery. If unrecognized or untreated, malignant hyperthermia results in death. Fluids are lost during the surgery through blood loss, hyperventilations, and exposed skin surface. Volume may be replaced with the IV fluids, and excessive blood loss replaced with the blood products, colloids, or crystalloids. The body naturally retains fluid for at least 24 hours to 48 hours after the surgery due to the stimulations of antidiuretic hormones as part of the stress response and the effects of the anesthesia. The patient should be monitored for fluid electrolyte balance, pulmonary edema, and water infections. Fluid intake usually exceeds output during the first 24 to 48 hours. Even if the IV fluid intake is 2,000 to 3,000 milliliters, the first void may not be more than 200 milliliters. Nausea and vomiting is a common postoperative problem and can also lead to fluid and electrolyte imbalance. It is often caused by the effects of the general anesthesia, abnormal surgery opiate, analgesics, and history of motion sickness. Nausea and vomiting usually occurs in the first 24 hours with the highest incidence in the first 2 hours. It can prolong recovery, sometimes resulting in an unplanned hospital admission for the outpatient surgery of the patient. Pain is common occurrence after most all types of surgery procedures and is probably the most significant postoperative problems in the eyes of the patient. Prompt and adequate pain relief is a critical nursing intervention. Unresolved acute pain has many negative effects, including more complications, longer hospital stays, greater disabilities, and the potential for chronic pain. There is an association between the high pain scores and nausea, respiratory complications, slower return of GI functions, increased risk of DVT. Effective methods of post-operative pain relief includes analgesia, which is given prior to surgery or prior to pain. Giving around-the-clock analgesia or PCA or patient-controlled analgesia, PRN or as-needed dosing. Management of breakthrough pains and non-pharmacologic interventions. Assessment of the patient's pain is the first priority. The patient's report is the most reliable indicator of pain intensity, and using a numeric or faces pain rating scale as a reliable tool. Other important assessments in the postoperative period include assessing the surgery site, is the dressing dry and intact, proper draining of the drainage, tubes and rate of patency of IV fluids, and level of sensations after regional anesthesia. Circulation and sensation in the extremities after orthopedic or vascular surgery, and patient safety. During the patient's stay in the PACU, the nurse documents all the assessments and interventions. Patient usually remains in the PACU until their vital signs are stable and they are reasonably capable of self-care. Discharge from the PACU is usually determined by a numeric scoring system. The most common within uses is the Aldrich score. There is a phase 1 Aldrich score that measures activity, respiration, circulations, consciousness, and oxygen saturations or color. Each measurement is scored from 0 to 2 with a total score of 9 or 10 qualifying for discharge from the patients to the PACU. The anesthesiologist often discharges the patients from the phase 1. The phase 2 Aldrich score is used for the patients who are conscious or those who receive local or regional anesthesia and have moved on from phase 1. The patient will be then discharged to home or short stay unit or inpatient unit. If the patient is staying in the hospital unit, the PACU nurse gives report to the nurse in the patient unit who will take over the care of the patient. When the patient moves to the inpatient unit or the short stay unit, they are in the third phase of the post-anesthesia care, the ongoing post-operative care.